Imagine walking into your medicine cabinet right now. Somewhere in there, tucked between the vitamins and the cold medicine, might be a small orange bottle that your doctor prescribed with the best of intentions. Something for your allergies, your sleep, your acid reflux. Something so common, so ordinary, that you've probably never thought twice about it. But what if I told you that some of the most widely prescribed medications in the world, drugs sitting in nearly every household in America, have been quietly linked to one of the fastest growing health crises of our time, cognitive decline? Not the medications you'd expect, not the ones with the scary warning labels. I'm talking about the ones your grandmother takes, the ones you might be taking right now. Tonight, I want to take you inside the science, real research, real data behind 9 of these everyday medications. We'll look at how they interact with the brain, why the risk has been hiding in plain sight, and most importantly, what you can actually do about it. This isn't about fear, it's about awareness, because the most powerful medicine is often the knowledge to ask your doctor the right question. Let's begin. Let's start with a name almost every household knows: diphenhydramine. You know it better as Benadryl, the little pink pill you reach for when your eyes are itching, your nose is running, or you simply can't fall asleep. It's been sitting on pharmacy shelves since the 1940s, so trusted, so familiar that most people never think to question it. But here's what the research is now showing us. Diphenhydramine belongs to a class of drugs called anticholinergics. These medications work by blocking a neurotransmitter called acetylcholine, a chemical messenger that your brain relies on heavily for memory, learning, and communication between neurons. When you take diphenhydramine to dry up a runny nose, it doesn't just work locally. It crosses the blood-brain barrier and dampens acetylcholine activity throughout your entire nervous system, including the regions responsible for forming new memories. Now imagine this happening not once, but night after night, year after year, because you've made it your go-to sleep aid. A landmark study published in JAMA Internal Medicine followed thousands of older adults and found that cumulative, long-term use of strong anticholinergics like diphenhydramine was associated with a significantly higher risk of developing dementia, and the effect appeared to be dose-dependent. The longer and more frequently people used it, the higher their risk climbed. What makes this particularly striking is the sheer scale of exposure. Diphenhydramine isn't just sold as Benadryl, it's hidden inside dozens of nighttime cold medicines, PM pain relievers, and over-the-counter sleep aids with names that don't even mention its presence. Millions of people are taking it regularly, completely unaware that this seemingly harmless allergy pill is quietly interacting with the same brain chemistry involved in memory formation, potentially years before any symptoms would ever appear on a cognitive test. Now let's turn to a medication that millions of people, particularly women over 50, take every single day without a second thought. Oxybutynin, sold under the brand name Ditropan, is one of the most commonly prescribed drugs for overactive bladder. It's the medication doctors reach for when patients complain of frequent urges to urinate, especially at night, and for good reason. It works. Oxybutynin calms the involuntary contractions of the bladder muscle, giving people back a sense of control over their daily lives. But the way it achieves that relief tells a more complicated story. Like diphenhydramine, oxybutynin is also an anticholinergic. It blocks acetylcholine receptors, but not just in the bladder. Because it circulates through the bloodstream and crosses into the brain, it interferes with the very same neurotransmitter system responsible for attention, memory consolidation, and clear thinking. And unlike a short course of allergy medicine, oxybutynin is often prescribed as a long-term, sometimes indefinite, daily treatment. Researchers have taken particular interest in this drug because of a striking measurement called anticholinergic burden, which tracks the cumulative additive effect of these medications over time. Oxybutynin consistently ranks among the highest burden drugs on this scale. A widely cited study in JAMA Internal Medicine found that older adults using strong anticholinergics like oxybutynin for 3 years or more had a meaningfully elevated risk of developing dementia compared to those who never used them. What makes this especially concerning is that overactive bladder itself becomes more common with age, precisely the same window when the brain is most vulnerable to this kind of chemical interference, meaning the people prescribed this medication most often are frequently the same people who can least afford the cognitive risk it may carry. Let's talk about a medication that carries a very different kind of risk profile, one rooted not just in chemistry, but in dependency. Alprazolam, known to most people as Xanax, is one of the most widely prescribed anti-anxiety medications in the world. For someone in the grip of a panic attack or lying awake at 3 in the morning with a racing mind, Xanax can feel like an immediate and profound relief. It belongs to a class of drugs called benzodiazepines, and it works by enhancing the effect of a neurotransmitter called GABA, essentially turning down the volume on an overactive nervous system. That calming effect is precisely why it's so effective, and precisely why it's so widely used. But there's a trade-off happening beneath the surface. GABA doesn't just regulate anxiety. It plays a central role in how the brain forms and consolidates new memories. When alprazolam repeatedly suppresses the system, especially with the kind of long-term, regular use that many patients fall into after starting for what was meant to be short-term relief, the brain's memory circuitry can be affected in ways that persist well beyond the immediate calming effect. Several large-scale observational studies, including research published in the BMJ, have found an association between long-term benzodiazepine use and an increased risk of dementia, with some studies showing the risk rising the longer someone stays on the medication. What makes alprazolam particularly worth examining is how easily short-term use quietly becomes long-term use. A prescription meant to bridge someone through a stressful season can extend into months, then years, often without a formal reassessment, meaning the cumulative exposure many patients experience is far greater than either they or their doctors originally intended it to be. Now consider a medication with a longer history and an even more entrenched place in medicine cabinets around the world. Diazepam, better known by its brand name Valium, was once so widely prescribed throughout the 1960s and 70s that it earned the nickname Mother's Little Helper. It belongs to the same family of drugs as alprazolam, the benzodiazepines, but with one important distinction that makes it worth examining separately. Diazepam has an unusually long half-life, meaning it lingers in the body and brain far longer than many other medications in its class. Where some benzodiazepines clear the system within hours, diazepam and its active metabolites can remain present for days, continuously exerting their calming, GABA-enhancing effect on the nervous system long after a single dose was taken. For a patient dealing with muscle spasms, seizure disorders, or severe anxiety, this prolonged action can be clinically useful. But for the aging brain, it creates a different kind of exposure altogether, a near-constant, low-level suppression of the same neurotransmitter activity that underlies memory formation and cognitive sharpness. Researchers studying elderly populations have flagged long-acting benzodiazepines like diazepam as carrying a particularly elevated concern compared to their shorter-acting counterparts, precisely because the brain rarely gets a break from their influence. A study out of France published in the BMJ followed nearly 9,000 older adults and found that those who had used benzodiazepines, with diazepam among the most common, faced a significantly higher risk of being diagnosed with dementia in the years that followed, even after adjusting for other health factors. What makes this especially sobering is that many patients who started diazepam decades ago, during an era when its risks were poorly understood, may still be taking it today. Let's shift now to a completely different category of medication, one that has nothing to do with anxiety or sleep and everything to do with something as ordinary as heartburn. Omeprazole, sold under the brand name Prilosec, belongs to a class of drugs called proton pump inhibitors, or PPIs. It's become one of the most commonly used medications on the planet, prescribed for acid reflux and available over the counter for anyone who simply wants relief from that familiar burning sensation after a meal. It works by shutting down the pumps in the stomach lining that produce acid, and for millions of people, it works remarkably well. But here's where the story takes an unexpected turn. Because omeprazole suppresses stomach acid so effectively, it also interferes with the body's ability to absorb vitamin B12, a nutrient that happens to be essential for maintaining healthy nerve cells and producing the protective myelin sheath that allows neurons to communicate efficiently. Long-term suppression of stomach acid sustained over months and years can lead to a slow, often undetected decline in B12 levels, precisely the kind of deficiency that has been independently linked to memory problems and cognitive decline. Beyond the B12 connection, researchers have also proposed that PP1s may directly affect enzymes in the brain involved in clearing beta amyloid, the same protein implicated in Alzheimer's disease. A large German study published in JAMA Neurology followed thousands of older adults and found that regular PP1 users had a notably higher risk of developing dementia compared to those who weren't taking these medications. What makes omeprazole particularly worth highlighting is its sheer ubiquity, sold without a prescription, taken casually and often indefinitely by people who would never think to associate a heartburn pill with the health of their brain. Now let's turn to a medication that lives at the intersection of mental health and the aging brain. Paroxetine, sold under the brand name Paxil, belongs to a class of antidepressants called selective serotonin reuptake inhibitors, or SSRIs. It's prescribed widely for depression, anxiety disorders, and panic disorder, and for many patients, it has been genuinely life-changing, restoring a sense of stability during some of the darkest periods of their lives. Most SSRIs are considered relatively clean in terms of their side effect profile when it comes to cognitive concerns, but paroxetine stands apart from the rest of its class in one important way. Unlike other SSRIs, paroxetine also carries a notable anticholinergic effect, meaning that alongside its influence on serotonin, it interferes with acetylcholine activity in the brain, the same neurotransmitter system we've discussed with medications like diphenhydramine and oxybutynin. In fact, when researchers rank antidepressants by their anticholinergic burden, paroxetine consistently sits at the very top of the list, far higher than other commonly prescribed options like sertraline or escitalopram. This distinction matters enormously for older adults, who are often prescribed paroxetine for late-life depression or anxiety, precisely the population whose brains are most vulnerable to disruptions in acetylcholine signaling. Several studies examining anticholinergic burden and dementia risk have specifically flagged paroxetine as a medication of concern, noting that its cumulative use over time appears associated with measurable cognitive decline in elderly patients. What makes this particularly important is that depression itself can sometimes mimic or mask early cognitive changes, meaning a patient and their doctor might attribute memory difficulties to mood alone, when the very medication prescribed to treat that mood could be quietly contributing to the problem. Let's now examine a medication with roots that stretch back further than almost anything else on this list. Amitriptyline, sold under the brand name Elavil, belongs to a class of drugs called tricyclic antidepressants, developed decades before SSRIs even existed. Today, it's rarely prescribed for depression itself, but it remains remarkably popular for an entirely different set of purposes: chronic pain, migraine prevention, and even sleep difficulties, often given in low doses that patients assume are too small to cause any real concern. That assumption turns out to be misleading. Amitriptyline carries one of the highest anticholinergic burdens of any medication still in common use, often ranking at the very top of clinical scales that measure this effect, even above paroxetine and oxybutynin. It doesn't just block acetylcholine in one system, it blocks it broadly, throughout the nervous system, while also interfering with histamine and other neurotransmitter pathways that influence alertness and cognitive clarity. For a patient managing chronic back pain or frequent migraines, amitriptyline is often taken nightly for years on end, layered quietly on top of whatever other medications they may already be using. Researchers studying anticholinergic burden have consistently identified amitriptyline as one of the strongest contributors to cumulative cognitive risk in aging populations, with long-term users showing significantly elevated rates of memory impairment, and dementia diagnosis compared to non-users. What makes amitriptyline particularly deserving of scrutiny is the disconnect between how it's perceived and what it actually does, prescribed casually in small nightly doses for pain or sleep, while carrying a pharmacological profile intense enough to place it among the very medications geriatric specialists are trained to actively avoid in older patients whenever a safer alternative exists. Let's turn now to a medication whose very name has become shorthand for a good night's sleep. Zolpidem, sold under the brand name Ambien, was introduced in the 1990s as a supposedly safer alternative to benzodiazepines, a sleeping pill designed to work quickly, clear the system fast, and avoid the dependency issues associated with drugs like diazepam. For a while, that reputation held, and Zolpidem became one of the most prescribed sleep medications in the world. But as decades of real-world use have accumulated, a more complicated picture has begun to emerge. Zolpidem works by binding to the same GABA receptors that benzodiazepines target, and while its chemical structure is different, its effect on the brain's memory and consolidation systems follows a strikingly similar pattern. Every night that someone takes Zolpidem to fall asleep, they are also dampening the very neurotransmitter activity the brain relies on to process and store the day's memories, precisely during the hours when that consolidation is supposed to happen most efficiently. What makes this especially concerning is how Zolpidem is actually used in practice. Marketed and perceived as gentle and low risk, it's frequently taken nightly, for months or even years, far beyond the short-term use it was originally intended for. A Taiwanese study following thousands of patients found that individuals prescribed Zolpidem had a significantly higher risk of developing dementia compared to non-users, with the risk climbing further among those on higher cumulative doses. Sleep researchers have also raised a separate concern that Zolpidem may interfere with deep, slow-wave sleep, the very sleep stage during which the brain performs its overnight cleansing process, clearing away metabolic waste, including the beta-amyloid proteins associated with Alzheimer's disease. Finally, let's look at a medication so common, so unremarkable, that most people wouldn't even think to call it a drug at all. Chlorpheniramine is an antihistamine that has been used for generations to treat allergies, colds, and seasonal sniffles. Unlike diphenhydramine, which at least carries some brand recognition through Benadryl, chlorpheniramine tends to hide in plain sight, buried in the ingredient list of combination cold and flu products, allergy tablets, and nighttime formulas with names that give no indication of what's actually inside them. Someone reaching for a daytime cold medicine or a seasonal allergy pill rarely stops to read past the brand name on the front of the box. And yet, chlorpheniramine belongs to the very same first-generation antihistamine family as diphenhydramine, meaning it crosses the blood-brain barrier just as readily and blocks acetylcholine receptors with similar intensity. The difference is that because it's so often layered into multi-symptom products, people may be consuming it far more frequently than they realize, taking one product for daytime allergies and another for nighttime congestion, each containing its own dose of this same anticholinergic compound, stacking exposure without ever recognizing the pattern. Researchers examining cumulative anticholinergic burden in older adults have specifically flagged first-generation antihistamines like chlorpheniramine as significant contributors to long-term cognitive risk, particularly because seasonal allergy sufferers often take them repeatedly, year after year, for decades, without ever viewing them as a medication requiring the same scrutiny as a prescription drug. What makes chlorpheniramine perhaps the most important medication to close on is exactly this invisibility, a substance so deeply woven into ordinary over-the-counter life that its connection to memory and brain health remains one of the least recognized risks on this entire list.